All good.
Welcome everybody. I see some folks joining our live here on the Agents of Change Instagram. We have Dr. John and Dr. Reiko Sakai. Am I saying that correctly?
Yes, you are.
Okay, awesome. Here to talk about transforming our criminal justice system through a public health lens. We will discuss how mass incarceration can be addressed by treating mental illness and drug addiction as public health issues, not crimes. The criminalization of Black and brown youth in our juvenile justice system, and the barriers to healthcare and health measures for those incarcerated that have existed historically and now, especially in the context of the COVID-19 pandemic. So without further ado, first, before we jump into things, I want to thank you both for taking the time as frontline healthcare providers. I know this is a very busy and crucial time for you both, so I appreciate the time taken out of your schedules set aside to educate folks in our community, and as well as thanking everybody joining us here on the live. If you could start by introducing yourself, tell our listeners about who you are, the work that you do, and what inspired you to join our discussion today. And Dr. Reiko, if you'd like to start.
Sure. Well, thank you, Nick. My name is Reiko Sakai, and I'm a pediatrician in Salinas. I live in Seaside. Fairly new to the community, but really proud to have been welcomed here. And I think what inspired me to join this discussion has been just the fact that I've been so welcomed as a newcomer in this community, and inspired by the patients and the families that I get to take care of, the children and all of their families. And then also, I think specifically, one of the ways I connected most directly with Agents of Change has been around the issues of criminal justice, and specifically sort of looking for new solutions and new innovations in more restorative and community serving justice practices. And then also Agents of Change being really critical in my understanding and awareness of what's going on in terms of COVID-19 in our detention facilities in our county. And so, yeah, I think that's why I'm here, and I'm really honored to join you.
Thank you, Dr. Sakai, and again, thank you for being here. Dr. John, if you could tell us a little bit about yourself, the work that you do, and what inspired you to join our discussion today.
So thanks for the opportunity. Thanks the chance to meet other providers in down who are doing great work. I've been in Salinas for many years now, too many to count. And I've worked in a lot of organizations, including most of my practice has been on the east side, either the Sanborn Road stretch or the Laurel Drive stretch, having had privileges at Natividad Medical Center for almost 40 years. And presently I work at Soledad Prison, Soledad Correctional Training Facility. And I've been there for over 2 years now. In terms of inspiration to come on board and join you is, I don't know, I think I have some useful experiences and recollections and connections that could be helpful going forward as we try to make more effective change. I think that over the years working in Salinas, there seems to be a window now. The medical profession itself seems to be understanding this whole notion of health equity and the social determinants of health. I was doing that work in the front lines in the field for years, but now there seems to be a framework developing around it that I think I'd like to be helpful with pushing forward. I think, and then in a small footnote, I think the entity or organization in town that was most helpful in making health equity an issue, a visible issue, was Building Healthy Communities, which has been a 10-year effort in Salinas that's pretty much winding up now, but they've laid a wonderful foundation for work like yours, work like the Agents of Change 831 is doing.
Yeah, thank you, Dr. John, for bringing your wealth of experience here to the table, and Dr. Sakai as well. And yeah, special shout out to Building Healthy Communities for all the wonderful work that they do. The first question, I think we want to just kind of start with a bird's eye view about, and I could share my screen here with some just information about, what is your, as health professionals working in public health field, what is your assessment, and if I could pull this up here, kind of how Monterey County is doing with the COVID-19 pandemic right now. Let's see, so if we look here, we have 4,000, almost 5,000 confirmed cases. It's a 42 case increase from yesterday. 302 hospitalizations, 34 fatalities, and almost 3,000 recovered here. And if we go further and break down, we could see the different numbers by the different age groups, as well as races. And I'm just going to pull up some more information here. And we could kind of refer to this as we go. But Dr. Sakai or Dr. John, what is your kind of assessment overall of how we as a county have been working to flatten the curve, as we say?
Sure, I'll let you go, Dr. Sakai. You work more county-wide than I do.
Yeah, absolutely. Happy to give my perspective. And it's my perspective. I'm a pediatrician. I do work at Natividad, and so definitely, we proudly serve a huge and really important portion of our community. So it's a little bit different, as I said, as a pediatrician, and these are just kind of my own interpretations of what we're seeing. But in my experience throughout this, I feel that we were all, especially with the first cases in San Francisco at Natividad, we were really in early April, just sort of bracing ourselves for the surge to hit pretty early there. And luckily, I think due to a combination of a few different things. So I think efforts on the county level in terms of, an early shelter in place order, mask, requirements. And then I think the fact too that April was a time where, and again, being a newcomer in this community, I can't speak with much nuance or sophistication on this at all, but where we were at in the agricultural season, and in terms of the movement of the members of our community who might do certain work at different times of the year, might be present and living in our community at certain times of the year, living in other communities at other times of the year. All that kind of amalgamation of factors, I think, did help us initially flatten the curve. And so I think what we're seeing right now, at least sort of anecdotally, at Natividad, is the surge that we were bracing ourselves for. And so, I'd love to give, again, my thoughts on, like you said, Nick, on what are some of the reasons that we are having a surge? What are some of the reasons that certain members of our community are disproportionately impacted by that surge? But one thing, as far as my take as to how we're handling it, I do see that at Natividad, at least, we've been able to have access to adequate personal protective equipment, PPE, and that we have a very distinct culture there of proudly serving many people who do not have insurance, many people who are currently or formerly incarcerated, many families who are agricultural workers. And so a lot of us take pride in that and are very aware of some of those forces that are putting those communities, especially, or those members of our community, especially, at higher risk. And I, personally am proud of how we're dealing with it at Natividad in terms of providing high quality care. We've had this isolation unit set up since April, as we anticipated this happening. And that has enabled us to, I think, provide really high quality care. As far as, like I said, getting to why some of these members of our community are even more impacted. It's a really complex question, but I think, and Dr. John mentioned social determinants of health, and that's sort of my background, my training, and my personal view as a healthcare provider is really critical in that. And another way, so social determinants of health meaning where you live, what type of housing you have access to. Do you struggle with food insecurity? What type of access to childcare do you have? What types of, what is your built environment? What are the, especially also, I think one of our focuses today might be access to mental health care services. And so another way to look at all of those determinants is to look at what are the things that impact them and make them increase those challenges for certain people in our community. And so sometimes in my training, a newer term that we've started to talk about is structural determinants, or even structural violence, because the reality is there are violent structures that are actually that are leading to those types of forces. So, housing insecurity, food insecurity, lack of access to mental health services, high rates of incarceration, right? So some of those forces, are, in my opinion, one of the biggest forces is, in essence, racism, right? So we have about 59, I think we cited about 59% of our community here in Monterey County is Latinx, and yet there are much higher rates of hospitalization with COVID and death with COVID proportionally, right? And so when we talk about structural violence, that's saying this confluence of those factors as far as communities that are dealing with difficulty accessing housing, food, and adequate healthcare, insurance coverage, that are putting them at higher risk for many diseases, and certainly, and then also sort of what jobs are they working? What is their kind of movement in the community doing to impact their risk and exposure? And so, the reality is when we're talking about agricultural workers, there's many sources of structural violence that are converging upon them in terms of, healthcare coverage, access to housing. Again, I'm repeating myself, but that's sort of the lens that I look at, certain members of our community suffering more from COVID. And I'd love to hear Dr. John take it away.
Yeah.
Stop my rambling.
Yeah, I think
if you don't, thank you for your thoughts. And there's some folks, and if you don't mind, while you're talking, Dr. John, I'm just going to be typing in what the topic of our conversation is, something I forgot to title. But for those of you who are just tuning in, we are joined by Dr. John and Dr. Sakai, talking about, transformative solutions to our criminal justice system through a public health lens. So how can we end mass incarceration by tackling some of our social ills through a public health lens, as well as the structural racism that leads to health problems, as well as interactions or touch points with the criminal justice system for marginalized communities. So I'm just going to be typing that, summary of that into the chat while you're sharing your response. So go ahead, Dr. John.
Yeah, I think that's a wonderful summary you gave, Dr. Sakai. From what I see more on the ground with the work I do is, the people that have a challenge getting care or getting information about a condition. Salinas has historically been a working class community, and the workers are a particular group. They're immigrant farm workers who make very low wages. And kind of the essence of health equity is to try to level the playing field for communities like that. And boy, trying to get to an indigenous speaking, a Triqui speaking woman who picks strawberries in Watsonville, trying to get that message about the transmissibility of COVID-19, that's a very challenging task. So I think that what we're seeing now, contributing to the surge now, I believe, is that message getting there late. That message getting to the most vulnerable population late. And as it is now, probably there is no translation of what a virus is, COVID-19's communicability to a Triqui speaking woman who works the fields. Compounded to that is the inability to really offer social distancing, for example, on the way to work and in the bus that she must take to get to work. And then once she's at work, the message about personal protective equipment was also late arriving to that population. So yes, it's not surprising to me that we are getting this late surge. It continues to be disproportionately Latino people from zip codes 93906 and 93905. So I think we're working on it. There are good collaborations in place. The Monterey County Coalition on Ag Worker Safety is a group that has been meeting every Monday evening from 5 to 6, which is a very wide collaboration. It does include the growers, but it's just a Herculean task to get this message out. And you'll notice in California that the more agricultural communities are getting their upticks and their rises later than the rest of the communities have. So those are the kind of challenges that a town like Salinas is challenged with at this moment.
Absolutely. I did want to, just as you said, Dr. John, one of the challenges when we're talking about language barriers is definitely some of one thing at Natividad that's so great is that we're very blessed to have in-person Indigenous interpreters of Triqui, Mixteco, Zapoteco, Chatino, and but you're right, COVID or no COVID, there's some things that are difficult to translate. But one thing that I just want to let the audience know as a resource is the Indigenous Interpreting Program at Natividad has actually made a series of PSAs in the Indigenous languages about COVID-19, doing to the extent that that language can, the interpretation, the translation can allow, just get information out about what coronavirus is and about PPE and about social distance and all these things. So I just, wanted to share that quickly, but it doesn't take away from all the other things, as you mentioned, transportation, housing, all these other challenges that especially Indigenous agricultural workers tend to have challenges with, for sure.
So yeah, I think that's where we are. And it's not just Monterey County, it's Imperial County is having a terrible problem with this. Same idea. The other counties south of ours that have a lot of strawberry pickers. So we're in the midst of it now, and it's good to finally hear someone use that word surge about Monterey County. I hadn't heard that yet, but clearly that's just
me.
Well, it certainly,
who knows if it's warranted.
It certainly feels like it. I checked Luis Alejos, Supervisor Alejo's daily to check the numbers, and last time I checked, the positive rate is almost 10%. Friday, I believe, the test positive rate was almost 10% in Monterey County. And to give you a comparison, I just came back from the East Coast. I was visiting family on the East Coast, and there in the state of Rhode Island, the positive rate is somewhere around 3%, the test positivity for COVID. So we're 3 times that, and public health policy will depend upon that rate as time goes on, and the inflection or the continue upward trend of that rate. We've got work to do in this county.
Yeah, and thank you for bringing those resources to light for our community that Natividad is putting for translation of important information around the pandemic for folks who speak Indigenous languages in our county, as well as bringing to light all these kind of structural what is the word? Structural determinants of health. Is that yes, right? Yeah.
Yes.
Like housing and transportation to work, and the work itself. Not being able to socially distance properly, or maintain certain social bubbles with work scheduling and things like that. So we see a huge surge in and disproportionate cases of those infected in our agricultural frontline economy. So many of those Latinx, just to kind of echo and amplify the statistics we talked about, is that 61% of our county's entire population is Latinx, yet 75% or 3/4 of the fatalities are from our Latinx communities, 85% of hospitalized cases. So just pretty startling numbers here, but I know that our county and healthcare professionals such as yourselves are doing everything that you can to help with this pandemic here. I wanted to talk about the structural determinants of we mentioned that agricultural industry, talked about, well, some of the others that I just want to name here are our educators and childcare workers and retired folks, are also some of the most vulnerable populations within the categories, disaggregated by employment industry. But for the focus of this conversation, I did want to talk about, those incarcerated and perhaps Dr. John, you could speak to this. What conditions in our county and state detention facilities make incarcerated people and staff particularly vulnerable to infection, seeing as, they're a small fraction of our population, but they're one of, I think, the top 5 infected industries. So could you speak to that?
Sure, sure. There's a lot here. Just some definitions and some background first. Soledad CTF houses probably close to 5,000 inmates, and right next door is Salinas Valley State Prison, which houses probably close to 3,000 inmates. So that's a pretty sizable population in Monterey County. So what conditions have made us more vulnerable? Certainly, it's a closed box. It's the inmates don't have free space to move around. They live in either 2-person cells, or in the yard that I work, they live in dormitories. Dormitories might have up to 150 to 200 inmates in bunk beds. So I think that's probably the main risk factor. The staff and the correctional officers, we come and go, we're able to enter and exit. So our experience isn't as dangerous, perhaps more so with the correctional officers who actually have to patrol the dormitories. The situation at, so the compacted nature of life there, the concentrated nature of life there is upon a background of the state of California Department of Corrections is coming out of a period of receivership where an outside entity had to take care and run the organization because of, I guess, a history of poor health outcomes amongst the inpatient population. So we're just now coming out of a situation of receivership where we had to reorganize how care was delivered. So I came on at the end of that. So we're operating under a new system now, more team-based care. We're using a complex care model where patients or inmates have a primary care physician. We're trying to mimic what happens in the system outside, the quote unquote healthcare system outside. So I think the system itself is getting better, but the inmates that I see day in and day out are really victims of prior, really unfortunate and substandard, subquality healthcare. We're trying to turn that around. So there probably is an underlying base of illness there. Cancer, for example, untreated cancers, diabetes, other chronic conditions that for 20 of the last 25 years have not been cared for correctly. So the patients are more ill. Long story short, the patients are more ill, more chronic disease. Care, as I said though, care is improving. So I think that's a couple of factors why it's such a challenging and place to work. That being said, of the 4,000 patients that we have, 4,400 inmates we have, so far we've only had 3 positive COVID cases, okay? And that's a good thing. Travel 150 miles north of us, though, and San Quentin has had a terrible experience with COVID. And then travel 200 miles to the south, 300 miles to the south, two LA prisons have had a terrible experience with COVID. It's the situation is so bad in San Quentin that I understand half of the inmates, approximately half of the inmates are COVID positive. And at last count, I saw they had 22 deaths from COVID. As of Friday, they had 22 deaths from COVID.
Wow. Yeah, we have a question. Thank you, Dr. John. In the chat here is, what is the availability and usage of masks like these masks in these facilities?
So at the correctional institutions?
Yes.
So we were slow. We were a little bit slow. We were a little bit tardy in getting the masks together, like much of the nation was in terms of PPE, that is personal protective equipment. At this point, it's not a problem. I want to say 8 to 10 weeks ago, the system itself started repurposing inmate labor to produce masks. So for the last 2 months, we've had state issue inmate produce masks. And so all the inmates have those now. All the correctional officers have that. It was slow in coming, like PPE was throughout the nation, but it's not an issue at this point. Providers do have, of course, when it first hit, we didn't have enough N95 masks, we didn't have enough face shields, we didn't have enough gowns, but that, and you know, it seemed interminable. It seems like, when is this going to end? But that period did end, and we're up to speed now. And I have to say, I'm impressed at how well prepared we are in terms of the PPE. The distancing is getting better. The distancing, physical distancing was taken care of. We have a protocol in place for that. My clinic waiting room is never too crowded. Maybe 4 or 5 patients in the waiting room at one time. So little by little, the steps have fallen into place. And I really feel fortunate in that we've only had 3 cases at our institution so far.
Yeah, I wanted to kind of get to the point in which you talked about, you know, that a lot of folks are coming into our prisons with, you know, existing preconditions because of lack of, you know, access to healthcare and other structural determinants for health, as we talked about before. You know, there's, I also want to talk about, you know, what are the conditions that lead to incarceration in the first place? And I feel like, you know, Dr. John, the folks that you see in state prison might have had, you know, 1 or 2 touches with the criminal justice system already. Dr. Sakai, I wanted to go to you, and if you could just kind of, you know, from a pediatrics perspective, if you could just kind of explain to our followers a little bit about what the school to prison pipeline is and how it disproportionately incarcerates our Black and brown youth.
Yeah, absolutely. And this is from the perspective, there are many pediatricians who are experts on this, on, you know, the youth justice system, juvenile justice, but, you know, I'll speak from my own perspective as a general, you know, doctor of children, both inside and outside the hospital. And one of the things that, no matter our setting or how in depth we've gone into this, that we, I think all of us as pediatricians have some consciousness of, and varying degrees, hopefully, of trying to address it, is toxic stress. So toxic stress is a term that came out of another phenomenon, or another set of health determinants that we found, called adverse childhood events. So this is similar to what I was saying about structural violence and structural determinants of health, in terms of things that early on and throughout childhood actually change the brain and just total body kind of structure of children, and can make them more vulnerable to diseases, and also to not being able to cultivate coping mechanisms that in the face of challenges. So what I'm talking about here in terms of toxic stress are things like, the biggest one is family separation. And that can look in any kind of different ways. On maybe the most common level, it's separation of a two-parent household and the decision to be, not together in the same household. But on more destructive levels, it can be incarceration of a parent. It can be detainment, deportation. And so those are like the number one, like I said, most destructive examples of toxic stress that not only, obviously it's sort of intuitive, right? Like, of course, those things are difficult for children, and of course they're going to have long lasting impacts on them. But what the research is showing is that they're actually changing the architecture of children's brain, especially the younger that they are when this happens. So that research came out of Harvard. And then ongoing research is finding that beyond that, things like hormonal levels changing. So cortisol, the stress hormone, right? You can have that in normal or sort of productive amounts. You need that to, sort of increase your body's capacity to be in a fight or flight situation and acutely, sort of get out of danger. But when a child is continuously and repeatedly exposed to a toxic stress such as family separation, and certainly incarceration of or detainment, confinement of the child themselves, that's causing prolonged excess levels of stress hormones such as cortisol that can actually make them sick. So increased risk for other diseases such as diabetes, obesity, asthma. And then those are things that are also, we know, to be underlying health conditions that make people more vulnerable to COVID, right? So that's a whole separate, these are all sort of converging factors and themes that come up. So in terms of the school to prison pipeline, the way I think about it and the way some of the things that shape it are policing in schools, essentially. So and excessive discipline, especially for youth and children of color. And so we have some specific data that shows this, and that shows that we look at Black and brown children differently. So there was a study in 2017 that showed that Black girls, when compared to white girls of their same age, were viewed as less innocent, more early to be sexualized, and not as in need of comfort and protection. And that was seen as early as age 5 in Black girls. And we're still, at least in my sort of familiarity with the literature, still waiting on studies as specific as that for Latinx girls. But of course, we know that, the struggles of Black children are, carry over and are similar in some ways for some brown children as well. Some Latinx children or, indigenous as well, certainly is often a left behind group. And then that study came even earlier than that in 2014, a study of Black boys that showed that as young as 10, they were seen as suspicious, older, perceived it to be older than they really were, and presumed to be guilty of things. And so those are some of the attitudes that that can happen in various aspects of our society, but that are especially dangerous in schools, because then you end up seeing differential or disproportionate levels of discipline of those groups of children. So Nick and you and I just were looking at some data today that's showing among, for example, Black students, which represent about 15% of the enrollment in U.S. public schools, but represent 33% of those who get arrested in schools. So, we can draw, these things are not happening in vacuums, right? They're not coincidental.
It's more than twice their population in terms of percentage.
Exactly. And I also want to point out that those of us in the medical community are not exempt from this type of racism either, because that's what it is, right? So there are certain conditions they're mental health conditions that are also associated with higher rates of incarceration. So namely conduct disorder, which is a condition that's characterized by difficulty following rules, respecting the rights of others, and behaving in a socially acceptable way. And so, these are children who are, dealing oftentimes with excessive amounts of toxic stress, again, like we talked about, right? And so they might not have the coping mechanisms to deal with that. And then they get this diagnosis, but it's disproportionately Black, especially Black males, that are getting the diagnosis. So some data that I looked at showed that Black males are 40% more likely and Black females are 54% more likely to be diagnosed with conduct disorder as opposed to their white counterparts. And then that's even when you are controlling for trauma and behavioral challenges, like where they actually compared black males and white males with similar, I suppose it'd be difficult to do to design the study, but similar profiles of traumatic experiences. And still, they were given this diagnosis of conduct disorder at high rates. They're also given other diagnoses, which are completely different medical treatment and definitely different implications for later incarceration, such as ADHD. So the study found that Black males were 40% less likely to be diagnosed with ADHD and 32% less likely to get psychiatric treatment in general. And so those are some of the aspects of the school to prison pipeline that I see from a pediatrics perspective, from a child development perspective. And again, toxic stress is especially focused on these events happening early in childhood. But the reality is that the brain is developing all the way through our 20s, right? You don't turn 18 and your brain is mature either. And then we can go into the whole, how likely are Black and brown youth, how much more likely they are to be tried as adults for the same crimes as white youth as well. So that's my perspective on that as far as what's the forces driving this problem. I have some other kind of thoughts on solutions, but I want to give Dr. John a chance to weigh in as well.
Sorry, I'll let you go ahead. Before I lose my thought, if you could hold on to yours, Dr. John, I just wanted to, comment about, the school to prison pipeline from a, education perspective. Being a teacher, and Dr. Sakai, I feel like you gave a really comprehensive explanation about, okay, how are Black and brown youth disproportionately affected by this school to prison pipeline, this funneling of our youth into juvenile justice and other forms of detention and correction. So, working in inner city youth programs and who in communities that disproportionately have less access to healthcare, less access to psychiatric support, as you were saying, and as well as increased exposure to violence and trauma. I was hearing of this term being spoken of, where it's not post-traumatic stress disorder. They PTSD. They identified as CTSD, which is like compounded traumatic stress disorder. So it's a continually, whether it's through separation of family, through incarceration, or just legal or living separation, but also, abuse and neglect in families that's brought about by generational trauma, in which, it becomes a problem that, a family needs professional support in, and that in this case, our public health and our officials and our state and local officials have yet to intervene in a very impactful way. So as an educator, it's something that I noticed. Students who, I'm just working with these kids during the summer. Students who exhibit symptoms of ADHD don't have a IEP, meaning they're not getting the support services they need to be able to develop those coping mechanisms and those social skills in order to successfully participate in a community. And that is when they start to withdraw, they start to see the system as something that's leaving them out, so they no longer participate in expected behavior. And that's when we see these youth engage in criminal behavior, because they might find some belonging or some kind of influence in these negative behaviors in a way that makes them feel full, in a way in fulfillment that they're not getting in other aspects of their life, whether school or home and in their community. So I just wanted to mention that. So Dr. John, if you could add your thoughts as well.
Yeah, a couple of things. First, in terms of what Dr. Sakai was mentioning about, I'm really happy that you mentioned the adverse childhood events or adverse childhood experiences. If you look back to the original studies, I think in the 90s down at Kaiser San Diego, one of the adverse childhood experiences that we don't talk about a lot is that of extreme poverty. Now, they didn't just describe poverty, they described that situation of extreme poverty, which in my experience, in my humble experience, is rampant in Salinas, particularly in Northeast Salinas. So that's one thing that contributes to the health consequences later. as another adverse childhood experience. But I'm going to jump ahead to the adolescent and adult manifestations of these social determinant of health challenges and these ACE challenges. I talk to patients a lot. I'm a family physician. We're supposed to offer relationship-based medicine there. I can't get across to you how many of the patients tell me that what got them in trouble originally, these are people that have been in prison 25, 30, 35, almost 40 years. They tell me that impulsivity was a problem. They realize after many years of incarceration and many years having finally had a chance at behavioral health, they're still struggling with that psychologic or behavioral symptom of impulsivity, which to some degree is normal in adolescence, but in this group of men, it's over the top. They'll tell you that. Another deficit that many of these guys, as if it's a syndrome of incarcerated men, seem to miss is solid, strong coping mechanisms. They tell me that they weren't taught, they weren't modeled those kind of tools in their households growing up. Instead, they saw corporal punishment. They saw one of the questions on the ACE questionnaire is, have you ever seen your mother getting struck, right? Or your grandmother getting struck. So these guys are, the guys that I see are very clear in the symptoms that were totally unmanaged when they were in their teens and into their early 20s. And many of them are grateful that they did get help once they got to prison. Many of them, those that did make a change ultimately say that it was behavioral counseling. And one of you alluded to it earlier, on the outside, it is, especially for communities of color, it's nearly impossible to get behavioral health in the traditional way. You know, that is to go see your corner, on the corner community psychologist. That just doesn't happen. And that doesn't mean that the avenues aren't developing to get that kind of care for young people. They really are nowadays. But still, the traditional model of a child that has ADHD, the pills, the meds may or may not be effective. What they need is family effort and individual effort toward behavioral change and those kind of things. Another example of structural racism. Those kind of things aren't often available to brown and black men. So that's what I noticed about the ACEs, the adverse childhood experiences, and how it translates to the adult and adolescent population that I see. And it's an epidemic amongst incarcerated men.
Yeah, and I just want to amplify, you know, that observation as, you know, and as an educator that I notice is that, you know, working in both public schools where, you know, you have so many, you know, Black and brown children who go undiagnosed because of lack of resources. It takes a lot of time to, you know, get whether it's attention or learning differences or behavioral, I'm trying to think of, you know, the right word, but, you know,
Intervention.
Yeah, behavioral intervention and these things diagnosed. And then, you know, I also worked at private schools where, you know, they have a, you know, counselor available on staff. They have, you know, early intervention of, you know, observing students, you know, and testing them early on if they do suspect that they might have some learning differences or need extra social emotional support. And they have these really robust social emotional learning programs where students are able to learn the skills, the coping skills, restorative justice skills, and you know, healing skills both with themselves and with their peers and as a community, in order to deal with you know, conflict and challenges in a positive way. And you know, I constantly talk with other educators where, you know, our folks incarcerated in the system are just, you know, those kids who weren't able to, you know, learn and practice those skills as youth. So it is a huge issue, and thank you for speaking on that. Before, you know, we kind of wrap things up, I wanted to talk about kind of what solutions do we have to stop the spread of COVID within our correctional facilities. In the long term, you know, how could we help to end mass incarceration through and improve the health of our communities as a whole through a public health lens. We've already kind of touched on a couple of those solutions already, but I do want to go to, there are a couple questions in the chat here that I do want to address. Let me just scroll up here. Okay, so we had a question about our farm workers, is that some county supervisors claim that corporate ag has done some things to address high housing density. Has this actually been happening in practice? So this is more of a housing agriculture issue. I'm not sure if that either of you can answer that.
Well, I mean, quickly, certainly there is a movement to improve farm worker housing. There is an effort by companies like Bud Antle, Foxy Lettuce, to collaborate with local builders, getting infusions of federal and state money to put up facilities. But it's a beginning effort, and it doesn't hit at the volume of the problem. So it's a good beginning. Let's see where it goes. I do think we have good assemblymen and supervisors who are poised to take advantage of funds that become available. We're in a tremendously inequitable beginning for that.
Yeah, I think
let's be positive.
Right. Yeah, let's stay positive.
Dr. Sakai, did you want to speak to that? Sorry.
No.
Okay.
Let's move through.
All right, thank you, Dr. John. So someone asked how much of the new jail costs. I'm not sure if either. I feel like, yeah, I don't know, but have we invested enough in our schools / health systems? What is your opinion?
No.
I'll let the pediatrician go first. Okay.
No. That's all I got.
Yeah.
No, I think the discussions that we've had recently, and I hope that are continuing on, reallocation of funding of our budgets towards the things that really foster the ability to for children to build coping mechanisms, right? So libraries, parks, after school programs. I think moving forward, more of this collaboration and integration of healthcare and education institutions. So I think there's so much more to go in terms of adequately funding both schools and health systems. But I'm really inspired by the work of Agents of Change 831, of all the different partners that you work with, and just many people and organizations in the community that are trying to push for the adequate funding that we need.
So there's an organization in town. Some of the women are over my shoulder. Maybe you've come across with them, Nick. They're called Padres Unidos. Have you connected with them yet?
I haven't, actually.
So it's a group of East Side mothers. I met with them about a year ago at a conference. And this is the kind of work we need to ally with and support more. When I was speaking to Maria, who is a leader of this organization, Spanish-speaking woman, she was saying, "Doctor, please ally with me about our main goal is to get a school psychologist in each of the LaSalle Union schools." Okay, so very ambitious undertaking, but the approach is, this is the direction we need to work in. The folks who are parents over there on the East Side need to express their voice, because that's what happens in those private schools that you were alluding to, Nick, before. The parents speak up and say, this is what we need. This is what we want. This is what you're going to do for us. So efforts like that are happening to a large extent over on the East Side. They just need time, and they need advocacy and allyship, and it is coming. I have seen evidences of progress in that respect.
Yeah, thank you, Dr. John. You said that was Padres Unidos is the
Padres Unidos, and okay. we can offline. I can give you the principles over there.
That would be great. Thank you. Yeah, in terms of in the context of this pandemic, what do you feel needs to be done immediately to stop the spread of COVID-19 in our correctional facilities?
Ooh, so I would recommend that yourself and all of you listeners read a book that came out last March, called Life and Death at Rikers Island. And it was written by a former medical director there named Homer Ventris, Ventres. And he talked about the disaster that was and still is Rikers Island, which is the main jail for New York City. And basically, his book talks about, it all begins with a data and a data collection of the correct data, and then quality of care approaches toward remedying the data. Practice interventions, plan, do, study, act type of interventions, showing the city councilman of New York City what's working and what isn't, and just keep working those cycles. That I think to a large degree, because of the financial receivership that CDCR had to go through, that we changed our practices. It happened before I got there, but right now with this model of care called the complex care model, data at all the institutions, it's a very powerful data set that drive our policies and how our teamwork goes. So that's from an internal standpoint about what's going to make it better. From an outside standpoint is the public needs to know that data. And there is a tool, I may have shared it with you, Nick, already. It's called the COVID tracking, the CDCR COVID-19 tracking instrument. And it's public data. If you go to the CDCR website, you can get that. And it gives the public, the tax-paying public, minute by minute or day by day data on the COVID situation. So that's part of it, public awareness. But then we have to do something with that data. We have to go to our state assemblymen, our state senators. There's one state assemblyman in particular, Assemblyman Phil Ting, T-I-N-G, out of San Francisco, who seems to be quite interested in healthcare. He spoke to my union last October. I belong to the Union of American Physicians and Dentists. He came specifically to talk to us about workforce matters. But we have to act from the out. I described what's happening on the inside, which I think is improvement. Yes, there have been some famous mistakes made in the last month, okay? But in general, care is improving within CDCR. But to keep it moving, to get the funding, what it should be for this population, to get the early paroles happening, and they are happening, to get those happening and setting up a structure for the early paroles needs public advocacy and public appeal to some well-intentioned assemblymen.
Yeah, I wanted to talk a little bit about, Monterey County Jail. I think, the numbers in Soledad, because of your efforts, and I think from what I hear, kind of listening to family members and loved ones of inmates, and, kind of feeling that pressure, and those changes might have been made before you got there, as you were saying, Dr. John, to seem to have been effective in flattening the curve in Soledad. In Monterey County Jail, it's pretty different, and I'm just going to project a little bit of the numbers here. Yeah. Is that we have, actually, let me share my screen here. And is that my screen? Share. And then, yeah, here we go. So, yeah, so we have, early last month, on the 8th, just 6 cases here. Now we're up to 279 cases. I've been hearing reports from family members of, somebody whose son was in the new wing of the jail for, having DUI, and since he's been in there, unable to pay bail. 3 or 4 different cellmates have been filtered in and out. And then, there was a sheriff, I forget their last name, but one of the sheriffs was speaking this morning just talking about how, if someone tests positive, then, they're released out into the public because that's no longer part of their business. I mean, what do you think on a county level we could do to, knowing that it's, the population of the jail is more transient than our state detention facilities? What could our county do to help flatten the curve here and stop this outbreak that's happening in Monterey County Jail?
So I'm not an expert at all on what happens at the Monterey County Jail. The governances are completely different from county jail and state prison. But that number, the number that jumped off the page at me was the case positivity rate of basically 30%. And I told you, I believe I mentioned previously that Monterey County's case positivity rate is 9-point-something percent, 9.7%. So it's 3 times higher in the prison, in the jail, than it is in society. So that there are some structural matters about healthcare at the prison. If I can be that presumptuous, that's what it looks like to me. Certainly they're underfunded. The county jails are not funded to the same degree as prisons are. And that, it may be funding, although this is a pretty wealthy county, right? Ag itself brings in almost $10 billion to Monterey County. So then besides funding, it's the will to use the money in situations like the Monterey County Jail. That's one aspect. The other aspect I'll mention, and I'll be quiet, is, let's see, this whole notion of bail and you have to wonder how many of the prisoners that are there are only there because they can't make bail. And that whole situation, policy-wise, that has to change. Some municipalities and governments have gone a long way on neglecting bail, not neglecting, but forbidding, or whatever the right word is, jail for people who can't make bail. I think New York City or the state of New York has gone that far in its policy. But that would certainly because of the nature of our community, which we talked about earlier, the historic low wages, that would make a big difference in Monterey County's jail population, concentration, and density, which would then lower the case positivity rate, right? Because you wouldn't be so packed in. So
yeah, exactly. I think the sheriff mentioned recently, and has probably spoken extensively since I personally heard these words come out of his mouth, which is that there was like a state mandate, I believe, or some sort of requirement for, like you said, Dr. John, zero bail that sort of expired, and that what the sheriff said at Monterey County is that they chose to continue to maintain that practice out of their own, that was their choice. But I think, the issue there is that, like, when it's sort of at their will, like, to what degree is it really happening if it's not mandated? So
on the positive side, we do have Councilman Alejo, 1st District, which is basically Salinas. He's a former family lawyer. I think that, Nick, if a case could be made to someone as well versed in the law as he, I think we could make progress on changing the bail situation, getting people into prison.
Yeah.
So I think there are some windows of opportunity here at this moment. The Board of Supervisors is changing, and it could change a lot in November. There's another candidate. I won't mention names, but if she's elected, it'll really sway the board more favorable for Democratic causes.
Okay, thank you. We're gonna get kicked out of our live in about 45 seconds. So if if you could just, any last words for our followers tuning in out there about, anything that we talked about in terms of de-incarceration and addressing, many of our social ills through a public health lens to really build up the health in our communities. Dr. Sakai, do you want to share any last words?
Yeah, I think just this partnership again of healthcare and educators is really powerful in addressing the school to prison pipeline. I think the advocacy from the community to get mental health services in schools is amazing and needs to be lifted up. As Dr. John mentioned, we have very real, concrete efforts happening towards that end. And also, I think we have to give credit to the many who've spoken to getting police out of our schools. And that's what I want to support.
All right, thank you, Dr. Sakai. The live just ended, but we're still recording, and I'm going to post this later. But Dr. John, if you want to send your closing statements,
just part, you know, in as few words as possible, partnership around our efforts. There's a lot of good things happening in Salinas. If we'd be so much stronger as if there was a model for us to work in a coordinated, more powerful manner. I think the building blocks are there. It's just the kind of work that agents of change are doing. If we can, I heard one of my colleagues recently was talking about partner mapping. So partner mapping around mass incarceration. I think the building blocks are in place. It's just coordinating them.
Yeah, well, thank you so much for bringing your wisdom and your expertise to the table, and all your imaginative thoughts around these really important issues to our community. And I hope you both have a great night, and thank you again for joining us.
Thank you. Thank both of you
Thank
for this
you.
opportunity.
So nice to meet you all.
Nice
Thanks
to meet
so
you as
much.
well. Bye.
Looking
Have
forward.
a good night.